be part of the group that's developing technical assistance materials to support the implementation of SB 1004. Today's webinar is on the second topic in the series, variables that impact the cost of delivering SB 1004 palliative care services. Next slide, please. So just as a reminder, I assume if you're on the call, you're pretty familiar with SB 1004, but just in case, SB 1004, Senate Bill 1004, which was signed into law in 2014, requires the Department of Healthcare Services to establish standards and provide technical assistance for Medi-Cal managed care plans to ensure delivery of palliative care services. And palliative care, as defined in this law, is patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. And palliative care, as defined in SB 1004, may be provided concurrently with curative care and does not require the beneficiary to have a life expectancy of 6 months or less. Policy documents, contact information for DHCS, and other materials related to the implementation of SB 1004 can be accessed at the SB 1004 website, and I've given you the URL there. As of today, it is my understanding that there is an implementation date of January 1st, 2018, though I'd encourage you folks who are with health plans to use your usual mechanisms for interacting with the state, the managed care division, about release of APLs, and you may in fact have more up-to-date information than I have. The information that will be presented in this webinar reflects the content of the May 2017 draft APL, and it's my understanding that that is still in draft form, but that there shouldn't be any major changes to that expected when the final comes out. Next slide, please. So in support of SB 1004 implementation, and I should say I work in palliative care development, and I had the great privilege of traveling around the country and talking to a lot of folks about the status of palliative care in their region or their state. And I can say that there's a good dozen states, maybe dozens, who are just very, very jealous of what we have in California, that it's just a wonderful opportunity to have legislation like this that really will enhance access to palliative care for a very vulnerable population that is in very much need of it. So I'm very excited to be able to help with the implementation of this law. And in support of that, the California Healthcare Foundation has sponsored this technical assistance series, which is aimed at both folks affiliated with the health plans, the Medi-Cal payers that are responsible for implementing it, and then also the provider groups that might be providing the palliative care services to the eligible beneficiaries. And Kinderman and I, Dr. Ann Kinderman from Zuckerberg San Francisco General Hospital, she's the Director of Supportive and Palliative Care Services there, are going to be presenting to you all technical assistance related to some of the core tasks related to launching and sustaining community-based palliative care programs. So back in July and August, we tackled topic 1, which was estimating the number of members who would be eligible for SB 1004 palliative care. We did a webinar and we had 3 workshops, and those were great fun. Hello to everybody who's on the line who attended those. Today is topic number 2, estimating costs for delivering services. So really less about doing an actual calculation and a whole lot more about coming to appreciate the variables that will impact the cost of delivering services, and hopefully the things that both providers and payers can do together to try to achieve maximum quality with maximum efficiency, creating alignment between the scope of services and the cost of delivering care. The third topic will be evaluating current capacity for delivering palliative care. So what do you all have in place in your systems and in your regions that can, what types of services are there that can be used to deliver SB 1004 palliative care? The fourth topic is developing a strategy to expand services. So if there's a gap between what you're currently able to deliver and that estimated number of folks who are likely to need palliative care services, what can you do to bridge that gap? And topic 5, finally, is gauging and promoting sustainability and success. And that'll address things like metrics and how to go from a pilot program to a sustained service, issues related to keeping the good work going. And at this point, I'll just mention that we are recording this webinar, and that that recording and these slides will be distributed to everybody who registered for the webinar early next week. So no worries about that. Next slide, please. So today's topic about appreciating the variables that impact the cost of care delivery. The reason why we're addressing this is that it's just so central to creating a successful, sustainable program, and that's really, just anchored in this idea of achieving balance. You need to have alignment, balance between the scope of services that you're delivering and the cost of delivering those services. So the burden that's taken on by the provider organization, the amount of payment that the payer is putting out and that the provider is receiving, that there's a nearly equal relationship between what you're being paid and the cost of delivering care, and that payment amount feels sustainable to the provider organization, and that's guaranteed by having in balance and alignment outcomes that justify the investment. So cost of care really isn't as important as the care that's delivered and the positive impact that it's going to have on patients and families. But we need to think about cost of care and the variables that impact cost of care to make sure that we achieve that balance that will allow for sustainability. Next slide, please. So our objectives for today, for this webinar, and then these will be carried forward and expanded some in the workshops that will follow in October, and we'll talk about those at the end of today's webinar. Our objectives are to review the SB 1004 required services, so what is it that you have to deliver, to whom and by whom. Appreciate the service model and contract features that influence the cost of delivering care. And this is really cost from the perspective of the provider organizations. So payers have a whole different set of variables that you'll think about when you think about the cost of the program or return on investment or affordability of sustaining a program. But here I really trying to focus on what can the provider organization do, and then yes, at times in partnership with the payer to influence the way that care is being delivered and the environment in which, the administrative environment in which care is delivered, so that you can keep that cost of care as low as possible. We'll consider strategies to promote alignment between payment and cost. We'll consider issues that contribute to the quality of new payer-provider relationships, so leaning on some lessons learned from folks who've done this type of work before, who share a little bit of what they learned in doing so. And then I'll wrap up by describing the workshops that are going to be on this topic. They're going to be happening in October. Next slide, please. So just to review, to make sure that we're all on the same page, the SB 1004 population, this is described in detail in both the policy paper and in the APL, and I'd refer you to the SB 1004 website that DHCS maintains to see the details there. But generally, the SB 1004 population is defined by a combination of general and disease-specific criteria. There's 4 qualifying diagnoses: COPD, advanced cancer, heart failure, and advanced liver disease. In addition to having a qualifying diagnosis, there's a number of criteria that require that there be evidence of advanced disease, that these are folks that are actually quite sick. And then also a few of the criteria speak to patient and caregiver or family preferences, such as a willingness to participate in advanced care planning, and a willingness to trial home disease management before calling 911 if a crisis occurs. Next slide, please. For that eligible population, there are 8 required services and 1 recommended service. And again, I'll refer you to the APL and to the policy paper to see the most current versions of these, or the official versions of these. But the required services are advanced care planning, a palliative care assessment and consultation, plan of care, a palliative care team, care coordination, pain and symptom management, mental health and medical social services, chaplaincy services, and then as an option, assuring that there is 24/7 telephonic support, in particular for pain and symptom management. And I actually like to look at these in some detail. I know that I came to know the eligibility criteria much more intimately when we were doing the work to prepare topic 1, and I do think it's important that we get really comfortable with understanding what is and what isn't in the official version of required services as we're thinking about options for care delivery. Next slide, please. So the first required service, advanced care planning. Advanced care planning for beneficiaries enrolled in Medi-Cal palliative care includes documented discussions between a physician or other qualified healthcare professional and a patient, family member, or a legally considered decision maker. And that counseling can take place during those discussions. It could include, but it is not limited to, advanced directives and completing other documents such as a PULSE form. So note that it says between a physician or other qualified healthcare professional. So there's a required service, but there's flexibility in who can deliver it. Next slide, please. PC assessment and consultation. So the palliative care consultation aims to collect both routine medical data and additional personal information that you wouldn't typically see in a medical history or health risk assessment. During the initial or subsequent palliative care consult or assessment, topics may include but are not limited to treatment plans, including palliative care and curative care, pain and medicine side effects, emotional and social challenges, spiritual concerns, patient goals, advanced directives, including PULSE forms, and the identifying and getting the contact information for a legally considered decision maker. So these are the types of issues that would be considered in delivering a palliative care assessment and consultation. Next slide, please. There needs to be a plan of care. It needs to be developed in consultation with the beneficiary and or his representative. If they already have a plan of care, then that plan of care should be updated to reflect any changes resulting from the palliative care consultation or advanced care planning discussion. And the plan of care must include all of the authorized palliative care, including but not limited to pain and symptom management and curative care. So not only do you do an assessment and a consultation and get a sense of what's going on with this patient, but you then develop a plan of care, and that needs to be documented, and that needs to be revised, and that needs to be kept up to date. Next slide, please. These services need to be delivered by a palliative care team, and it's in the language that describes the palliative care team that the policy seems to get into the most detail about some of the important intent of the legislation. The palliative care team is a group of individuals who work together to meet the physical, medical, psychosocial, emotional, and spiritual needs of beneficiaries and their families, and are able to assist in identifying sources of pain and discomfort of the beneficiary. This may include problems with breathing, fatigue, depression, anxiety, insomnia, bowel or bladder, nausea, etc. The palliative care team will also address other issues such as medication services and allied health. The team members must provide all authorized palliative care. DHCS recommends that the palliative care team include, but is not limited to, a doctor of medicine or osteopathy, a registered nurse, licensed vocational nurse or nurse practitioner, a social worker, and a chaplain. So what they specify is what is the traditional 4 core disciplines that are, for example, referenced in the Joint Commission certification requirements for palliative care. So physician, nurse, social worker, and chaplain, but it may include other individuals as well. And this group works together to address a range of issues that would can be confronted, that are commonly confronted by beneficiaries with serious illness and their families. Next slide, please. Care coordination. So some member of the palliative care team, it doesn't say which member, should provide coordination of care, ensure continuous assessment of the beneficiary's needs, and implement the plan of care. So oftentimes it's done by several members of the team, but somebody needs to take responsibility for it. Next slide, please. Pain and symptom management is called out as a core component of SB 1004 palliative care. Adequate pain and symptom management is an essential component of palliative care. Prescription drugs, physical therapy, and other medically necessary services may be needed to address beneficiary pain and other symptoms. The beneficiary's plan of care must include all services authorized for pain and symptom management. Next slide, please. Mental health and social services. So counseling and social services must be available to the beneficiary to assist in minimizing the stress and psychological problems that arise from a serious illness, related conditions, and the dying process. Counseling services facilitated by the palliative care team may include, but are not limited to, psychotherapy, bereavement counseling, medical social services, and discharge planning as appropriate. I think many members of the palliative care team, in particular chaplains and social workers, may identify as a core service providing emotional support to patients and families, assisting with coping, and that's somewhat different from psychotherapy or bereavement counseling, but all of those fall into the domain of SB 1004 palliative care. Next slide, please. And finally, chaplaincy services. DHCS recommends that the managed care plans provide access to chaplain services as part of the palliative care team, and it is certainly the case that all, for example, certified palliative care programs, either on the inpatient or on the outpatient side, do have spiritual care professionals on the team. Next slide, please. Then in terms of settings and providers, again, we see quite a bit of flexibility in the language of the APL. MCPs may authorize palliative care to be provided in a variety of settings, so inpatient, outpatient, or community-based settings. MCPs must utilize qualified providers for palliative care based on the setting and needs of the beneficiary. So they don't specify, for example, that somebody needs to be board certified, but somebody needs to be qualified based on the needs of the beneficiary. DHCS recommends that MCPs use providers with current palliative care training and or certification to conduct palliative care consultations or assessments. And these services may be provided through contracts with hospitals, long-term care facilities, clinics, hospice agencies, home health agencies, and other types of community-based providers that include licensed clinical staff with experience and or training in palliative care. So this care can be delivered in a lot of places by a lot of different types of providers working in different types of organizations. There's a requirement that you have training and expertise, but what constitutes adequate training is left up to, at least in the language of the APL, is left up to the discretion of the managed care plan. Next slide, please. So if you think about what was specified in terms of the services and the settings and the providers, to use language put forward by Marv Gordon of HealthNet, who I thought put this very succinctly and very well. The policy specifies the what, but the how is not specified. So there's no discussion of staffing model, how much effort is going to be required from each of those disciplines, and which disciplines tackle which of the specified services. There's no specificity around the frequency or types of encounters and whether those encounters would happen in the patient's home, in a clinic, over the phone, or through a video visit. There's nothing that's specified about the process for verifying eligibility, but the eligibility criteria are very specific and are spelled out in great detail. It doesn't say if that's the responsibility of the plan or the provider organization or some combination thereof. It doesn't talk about documentation and communication requirements, billing processes, authorization processes, all of these things that will contribute to how this policy is actually operationalized, and all of those things impact the cost of care delivery. Next slide, please. So for example, if you look at the required services, you'll see that they're very specific in some ways, that something needs to be done, so advanced care planning needs to be done, but there's several possible providers that could deliver those required services. And of course, those providers all have different salary levels, which will impact radically the cost of delivering care. So advanced care planning, that could be done by a physician, it could be done by a nurse practitioner or a physician assistant, it could be done by a registered nurse, it could be done by a social worker, it could be done by a chaplain, it could even be done by a trained layperson. For example, somebody who's gone through something like the Respecting Choices training. So all of those folks could be part of a team and fulfill that required service, but there would obviously be a big difference in how much it costs to deliver that service depending upon the disciplines that are delivering it. Palliative care assessment and consultation. Well, that could be done and very frequently is done in some programs by a nurse, a registered nurse and social worker team that is seeing the patient in their home under the direction of a medical director. But you could also have a care model where that palliative care assessment as consultation is done in reflects the collaborative work of a team of a physician, a nurse, a social worker, and a chaplain, all of whom may see the patient. Again, very different approach and very different cost for delivering that service. And then care coordination, that could be done by a physician, it could be done by a nurse practitioner, a nurse, or a social worker. It could also be facilitated by a nurse case manager that's employed by the health plan. So somebody who's coordinating or collaborating with a palliative care program, but isn't necessarily the cost of that support isn't included in the provider organization's cost of care delivery. So you can see there's specificity in what you have to do to comply with SB 1004 requirements, but there's also flexibility in how these services are delivered. Next slide, please. So if you think about the variables that drive costs, there's and this is for a provider, so there's the cost components. You have the cost of direct care effort, so the time that it takes to see a patient, the time that it takes to drive to their home and to document and coordinate with other providers, all of those sorts of things. There's also a whole bunch of operational costs that have to do with screening for eligibility, interacting with the health plan, submitting bills, getting authorizations, and so on. And then all of those costs may be some subset of what an organization would think about as their indirect costs. And all of those cost components are impacted by cost drivers, and I batch them into three categories. So one of the big cost drivers is the palliative care population and the care environment. So what is it that these patients need in particular that would make delivering those specified services perhaps more or less complex? And what is there about the care environment that may make delivering those services perhaps more or less complex? And examples there might be if you're in a rural setting as opposed to a suburban setting, or for example, if your population is incredibly linguistically diverse and you have to use a translator or interpreter services with nearly every encounter. There's also another cost driver category is the provider organization characteristics and the resources that it has at its disposal. So for example, if the provider organization, say a hospice that's gotten into the business of also providing palliative care, if they don't have a billing infrastructure in place, if they don't have that resource, or if they don't have an electronic health record that is set up to accept information about palliative care patients as opposed to hospice patients, then the processes for delivering care will be very different and will take different amounts of effort and will have different costs based on those characteristics and internal resources. And finally, the payer policies and preferences and resources above and beyond any policies that are laid out in SB 1004, that will have a big impact on the cost of care delivery. So the requirements that the payer has around securing authorization for palliative care services, or authorization for durable medical equipment, or how frequently you need to interact with some of their staff to assure ongoing eligibility or to ensure that the patient's needs are being met. And all of the many elements of these cost drivers, some of them are fixed. If you live in a rural area, you live in a rural area and you're not going to be able to do anything about that. But some of the cost drivers are variable and they reflect choices. And it's those choices, those decision points that turn into issues that can be negotiated between the payer and the provider, and that is where you have the opportunity to impact, or those are the things that will impact the cost of delivering care. Next slide, please. So I almost didn't use this figure because it's like so complicated, it gives me anxiety, but I wanted to share that with all of you. You can have some of my anxiety. I just really wanted to point out that in terms of the variables that contribute to direct care costs, and really the variables that contribute to total costs, they are multiple and they are interconnected. And every decision you make along the way can impact cost of care down the road, or the cost of the back office work that has to happen to support care delivery. So just to give you a flavor of this, you have the patient population attributes that impact the care model and the effort required to deliver care, and that includes things like poverty and which may contribute to food insecurity or housing insecurity, or all those things that go into complicating the delivery of medical care aimed at a serious illness. You might have folks in a rural environment where there's isolation and there's not family caregivers around to help. There might be comorbid mental health needs or addiction issues. You might have a really diverse population that makes it necessary to engage interpreters to help in figuring out patient goals and preferences. And all of those things have an impact on the cost of care. And all of those attributes impact scope. So the needs of the population determine the scope of services that you need to deliver to the patients. And SB 1004 outlines a particular scope, but what it allows for also is opportunities to collaborate. So you may have some services delivered by one organization, other services delivered by a partnering organization. So for example, some care may be delivered in a clinic setting by a safety net health system. Other care may be delivered in the home by a hospice or palliative care organization that the health plan contracts with. And then that scope of service, what components of care a particular organization is responsible for, that will dictate the care model. And then the care model has to do with the interdisciplinary staffing, so who's going to be on the team, and then also who's going to be on the team in which setting. If you're offering care in the home as well as in the clinic, as well as offering some services through video or voice, which of course is very different costs associated with those modalities. And then the scope of services that you're providing to meet the needs of the population, delivered through a particular in a particular setting, through a particular modality, using a particular team, well, all that impacts the care team effort costs. So the frequency of the contacts by modality, by discipline, the length of the contacts, the travel time, charting and communication and coordination work, IDT time, all of those things are influenced by those boxes that sit above it in this very complicated and alarming figure. And then all of those care team effort costs, those then contribute to other organizational costs. So if you're having to travel a lot, if you're doing care in patient's home, as opposed to making a choice to do it through a video visit or over the phone, then you're going to incur mileage and transportation costs. You may also, depending upon decisions made around how eligibility would be verified, you may have a whole lot of eligibility verification effort as well. So the point of this is that there's a whole bunch of things that will contribute to your costs, and those are all interconnected. And so as you make one decision, you are probably impacting costs downstream when it comes to sort of figuring out what are the resources that are required to deliver SB 1004 palliative care. Next slide, please. So the big message is that you really need to know your costs, and you really need to know which costs are modifiable. So working within the parameters of SB 1004 policy and the APL, you need to account for the time and the resources required to deliver direct patient care by all of the disciplines that you're going to include on your team, as well as the operational factors that will generate effort and costs. And that's things like screen for eligibility. That's things like billing for services and so on. And your challenge then, or what you have an opportunity to do, is make an assessment about which costs are fixed, which costs are just going to be there, and there's not a whole lot that I can do about them. And then you also need to figure out what choices are available to your payer-provider partnership to increase efficiency or reduce resource burden while maintaining quality. And there's quite a few of these. And what I really want you to encourage you to do, particularly the provider organizations, is to think about this with an open mind, to go into this with an eye to being innovative, with an eye to being flexible, and really thinking about what modifications could you make to create that alignment between your effort, your cost, your care model, the payment that's available, so that you can have a nice aligned win-win with the partnering payer organization. Next slide, please. So cost drivers and decision points. And when you think about those variables where there's an opportunity to impact the cost, where you can make choices about what you do, and that's going to result in more or less effort, more or less cost. Well, you can look at these categorically, and there's a sampling here for you. So population. So if you have a population that is linguistically diverse, you may well need interpreter services, but you can make choices about which type of services you're going to engage with or use. You may in fact decide to put a concerted effort into hiring bilingual or multilingual staff, so you don't have to go out and use an external organization. Scope is another area that drives costs, and where there's a number of decision points. Which services the palliative care team will provide, and then that will be dictated by any expected collaboration with other organizations, including the health plan. Is your palliative care organization going to be functioning as a team along with a behavioral health organization, or a population health management organization, or a local health system, or even resources available from the health plan, where you're pooling together effort to meet all of the needs of the patient population and to comply with the scope of services that are outlined in SB 1004. I should mention here also that scope would be impacted if a health plan makes a decision to provide more than the required services as outlined in SB 1004, or if a program or plan elects to engage with providers beyond the minimum that are specified. So that gets into model, so which disciplines are on your team, and it's which disciplines are on the team, and which settings do they work in. How frequently are they providing the different types of services in each setting? And here your options are clinic and office versus in the patient home, or seeing them in the nursing home, or via telephone and video. And are there mandatory minimums, for example? Is there is a payer preference to say the team must see the patient every 2 weeks? Well, creating a minimum like that certainly dictates a certain level of quality, a certain level of surveillance for the patient. There's a cost to be paid for that as well, in terms of, well, what if the patient doesn't need to be seen that often? Or could some of the visits be done via telephone or video as opposed to having to go out to the home? Those choices that are made about the frequency of visit and the modality of having the encounter with the patient have a radical impact on cost, particularly in areas where there's quite a bit of travel time. The strategy for ensuring 24/7 access, if your program will provide this, will you engage with an external organization that provides a triage service and an after-hours call program? Could you leverage a hospice staff? Do you already have hospice staff on call 24/7? And could they also take care of your palliative care patients? Or might you pay your clinical team to be on call and have a rotation of your clinical staff who take turns accepting call in the evenings and on weekends. Care team communication effort is a huge driver of costs, and it's really creating that balance of quality and effort. So how frequently will your interdisciplinary team meet? And are you meeting in person, or are you meeting over the phone, or are you meeting via Zoom? And also other internal provider organizational meetings. All of those times when you're gathering together as a group, when you're not out doing clinical work, and creating that balance between how organizational culture and also creating cost efficiency. The presence or frequency of meetings with external organizations. So, for example, are you going to the clinic to participate in rounds weekly to help with identifying eligible patients? Are you phoning in to health plan case management meetings so that they can have the benefit of what your team knows about what's going on with the patient? Do you have to engage in those meetings to secure authorization for ongoing services? Those sorts of things can really pile up, and taking a good long look at how much time are we spending communicating, what's mandatory communication, what's the amount of communication that we need to assure quality, versus are we starting to eat into our efficiency. That's one way to think about a cost driver and to recognize the decisions that you're making that might impact costs. Next slide, please. Operational factors are huge, and they are often overlooked as something that's really driving the cost of care delivery. So the effort that's required on the part of the provider organization to screen and enroll and disenroll patients. And this can be done on, there's just enormous variation in how this is done. Some payers pre-screen all of their patients, and if they're giving the palliative care provider organization a name, then they know that everybody on a given list is already authorized to receive palliative care. On the other end of the spectrum, some payers take no part in this. They leave entirely the burden of identifying eligible patients and screening them for eligibility on the shoulders of the provider organization. And that can be incredibly time-consuming, and so it's really important to recognize the effort that's required to do that work. Also, if there's disenrollment criteria, and does it have a need for ongoing authorizations, and also the probability that some enrolled patients might have periods of stability. If you have very tight disenrollment criteria, and as soon as a patient very quickly seems to not require in-home support right at that moment, and they are disenrolled from the program, then you're pretty much guaranteed to have a very sick, very active population all across the board. And so the provider organization would need to account for that when they're thinking about how frequently their patients need to be visited. It's also important to remember that if there's relatively little happening on the payer end in terms of screening patients who might be eligible, let's say they're just running a list based on primary diagnosis, and it's expected that fewer than half of those patients would actually be eligible for SB 1004 palliative care. If the palliative care provider organization is spending a whole lot of time screening patients who wind up being ineligible, that turns into lots of uncompensated effort if the only mechanism for getting paid is when patients are enrolled in the program and you start receiving, for example, a per member per month payment. So if that's the mechanism that you're going to use for screening patients, for finding eligible patients, you may want to make sure that your contract includes something that accounts for that effort, which could be quite substantial. Strategies for promoting referrals will be a big driver of cost, and is also a decision point. The extent to which the plan and the provider organization partner to orient referring providers to the program and to make it easy for those referrals to happen can really have a big impact on the number of patients that are referred, the number of patients who referred who are actually eligible, and also the case finding effort by the palliative care organization. So attending to that topic can really impact the amount of effort, and I would say oftentimes uncompensated effort, that the palliative care organization is investing. The strategies that are used to orient and engage patients and families to the palliative care service is another cost driver and another decision point. The more that's done so that patients and families know what palliative care is, that information is conveyed to them by an individual that they trust, the more likely they are to accept services. And again, you don't wind up in a situation when you've gone through the effort of identifying need, of investing effort in identifying that patient, but at the end of the day, they decline services. The effort that's required to gather and submit the data needed for payer case review and ongoing authorization, either for services period or to make sure that you, to determine if you qualify for, say, one of several possible payment tiers. That effort needs to be looked at and accounted for. If it's something that happens very, very frequently, or even in fact with every visit, then that effort needs to be factored in to the provider organization's estimates of cost, or the process for doing that work could be revisited. A different choice could be made about how much work needs to go into securing ongoing authorization, or how often somebody's payment tier needs to be verified. Effort required to secure authorizations for durable medical equipment and medication refills and so on. This can really be a substantial time investment on the part of the provider organization, and choices can be made. Processes can be put in place to introduce efficiency into this. So for example, you could have a single point of contact within the plan or within a referring provider group that the palliative care team can always use if they're looking to get an authorization for an enrolled patient. Alternately, if that's not in place and the provider organization needs to spend a whole lot of time trying to contact the palliative care provider, the primary care provider, to get permission to deliver services, that can be a big time sink, and it's important to account for that. The metrics that are required providers are required to report to the plan, and the proportion of those that are not simple extractions from an EHR can really build up into a lot of effort on the part of the provider organization. So a conversation needs to be had about which data are really needed, and if that list includes elements that just can't be pulled from an electronic health record, then the effort required to gather those data needs to be accounted for when you're figuring out the cost of care. And then finally, the process for submitting claims. Does the provider organization, are they able to bill, or some hospice organizations are not? What is their infrastructure like? Are they going to have to pay another organization to do that work? Alternatively, is there, even if there is a billing process, is there something that the payer and provider can do together with claims configuration that will allow for sort of a smooth and non-manual process for generating claims and facilitating timely payment? Next slide, please. And so as you think about all of these decision points, all of these cost drivers, you can start to break them out into the variables, the implications, and the options. So the patient or program characteristic that might drive cost, what that may mean for your organization and your costs, and then options for managing that variable so that you can potentially reduce the resources that your organization, your provider organization, needs to invest to be able to deliver palliative care. So for example, the target population is complex. There's mental health issues, poverty issues, a large proportion of individuals with substance abuse issues, linguistic diversity, etc. So what might that mean for your organization? And here I'm particularly wanting to call this out to organizations that may have a lot of experience delivering palliative care to, say, a Medicare population, but less familiarity with delivering services to a Medi-Cal population. It's going to wind up feeling very different. There's going to be different demands on your staff in terms of which disciplines spend which amount of time, and also the competencies that your staff might need. So that complex population, that might mean that you're doing more frequent visits than you would otherwise expect. It might mean that there's intense case management required. It might mean that there's a much broader set of services that this population requires to get the support they need so they can cope with now a very serious illness. And it may be that the team needs behavioral health training to help with managing some of these patients effectively. So what are your options then to try to impact the cost of delivering care? Well, you could collaborate with other organizations that have separate funding streams. So you could consider a bundle, a group of organizations that are looking to deliver care to these patients that would include a behavioral health organization specifically or a population health program that can help to manage the needs of this population. You could negotiate with the payer to provide case management support, to assign an RN case manager to all of the palliative care patients to help with It might be quite a bit of collaboration with providers that are still providing disease-directed care, or to help with other care coordination issues. You could, to manage an issue of diverse linguistic needs, hire bilingual or multilingual staff to reduce the need to hire to pay for interpreter services. So those are examples of characteristics, what that might mean for your service, and options for managing those in a way that might improve efficiency. Let's look at another example of that. Next slide, please. So it could be that considerable effort is required to secure authorizations for durable medical equipment or prescription approvals or for refills. And what that may mean for your program is that it could tie up clinical staff on the phone, so that's time they can't spend seeing another patient or documenting services or doing all the other important things they need to do. So what are your options for impacting that cost driver? Well, you could negotiate with the payer that there might be an exception to some rules while patients are enrolled in palliative care, so you can bypass some of the authorization work, or you could identify a single point of contact at the plan or within a medical group to handle such requests. And I would say for all of those cost driver categories, all those decision points that were detailed on the prior slides, you can go through this process of thinking about what's the program or the patient or program characteristic, what does that mean for us, what are our options for managing it? And this is the type of exercise that we're going to be spending time on in the upcoming workshops. Next slide, please. Next slide, please. Thank you. I also just want to briefly mention startup ramp-up costs. You know, these issues of how frequently different staff members will visit patients, and what is the optimal efficiency given a certain volume, and a fully trained staff, and a referring provider group that is very comfortable with the eligibility criteria. All of that assumes sort of a mature program and you know, sort of a mature referral base, having things going at capacity. And things are going to be different at first. There are startup costs if you're just beginning to offer community-based palliative care, you know, non-hospital palliative care. There'll also be ramp-up costs if you're suddenly taking on a largest new population. And those are discussions that typically happen separately from any discussion of, say, a per enrolled member per month payment, or a bundled fee-for-service schedule. And so you should be cognizant of those costs, and you should talk about them with your payer partners. And you should realize that those are a sort of separate and one-time, typically, as opposed to something that you would want to, say, fold into a negotiated contract rate right from the beginning. So you will see early on gaps between the revenues that you could be expecting and maybe the salary costs of new staff that you've brought on to manage a new volume while you're building your referral base. There will be costs associated with developing new workflows and developing data collection strategies and developing educational materials for patients and families and referring providers. And of course, there'll be an investment that's needed to orient and or train new staff in palliative care. So these costs are very real. They can be significant, but I encourage you to think about those apart from what you think your costs will be in your fully functioning, mature program. Next slide, please. So I just wanted to very briefly touch on lessons learned from others. You know, we're very fortunate that in California and actually across the country, there are a whole lot of groups that have been providing community-based palliative care for some time, and we have an opportunity to look at the lessons they've learned and then incorporate them into efforts aimed at promoting positive payer-provider partnerships, good relationships there, in addition to information that they've perhaps shared about staffing models and impact and ROI and so on. There was an initiative that will wrap up at the end of this year that was sponsored by the California Healthcare Foundation, a payer-provider partnership. It involved 6 teams of payer and provider organizations that came together to develop a plan for delivering community-based palliative care. Then it went into an implementation phase where contracts were developed and executed. And we had an opportunity to speak to the payers and providers who participated in that initiative and to hear from them about lessons that they've learned about developing and enacting an agreement to deliver community-based palliative care. Next slide, please. So I'm just going to share three of these lessons. We'll have time to go through a few more in the workshop, but three that I think are particularly important that I wanted to talk about today were the initial engagement period, this issue of promoting appropriate referrals and whose responsibility that is, and then relationship issues. Next slide, please. So initial engagement. So many of the payers and providers stress just how important this early phase is and just how important it is to take the time to meet in person, get to know your partner, sit down with them, talk to them, and when you're having those conversations, make sure that there's a common understanding of what palliative care is above and beyond the specifics that are outlined in SB 1004. Come to understand what each organization's goals are, what they're hoping to achieve, what success looks like, and then also each organization's priorities and pressures. And taking this time to learn about each other really lays the foundation for trust and for open communication. Next slide, please. Promoting appropriate referrals. We've talked about this a little bit, and there's a range of strategies from the health plan mining data to identify patients based on utilization patterns or diagnosis or indicators of advanced disease. There's a strategy of identifying appropriate patients by having referring providers, just telling them about the program, the eligibility criteria, and having them make the referrals, and then a hybrid approach, and really thinking about this carefully and the huge role it plays in the number of individuals that are successfully identified, and then the number of individuals who are actually referred, and the number of referred individuals who accept services. This is really, really important. And so spending time thinking about how can we promote appropriate referrals will really be time well spent towards the beginning of the payer-provider relationship. Also, creating and maintaining referring provider relationships is super important, particularly for an external organization like a hospice and palliative care organization that may or may not have a relationship with a medical group from whom they're hoping to receive referrals. Really, really important to develop those relationships and to have the health plan facilitate development of those relationships where appropriate. Next slide, please. And then finally, relationship issues. So many of the initiative participants stress this, that it's really, really important that you nurture and attend to the relationship with your payer or your provider partner. You do not want to be the last one to know that your payer or provider partner is actually really unhappy with the arrangement and they have no intention of continuing with it. So you need to talk to each other. You need to aim for building trust and being flexible and avoiding an understandable circumstance which could develop, which is kind of an us versus them attitude. Listening and transparency are valued highly. Collaborative problem solving is valued highly. Next slide, please. So just to wrap up, the all-plan letter specifies the eligible population, the services that are to be provided, and who should be providing those services. The minimum, what, is fixed and specified. The how you deliver those services is up to you, and that's a conversation that the payer and the provider will have together. Costs will be driven by the population and care environment, the provider resources and characteristics, and the payer policy preferences and resources. All of those things together will combine to dictate your care model, your cost of care, and all of that will eventually wind up in a contract. Some cost drivers are fixed, but many are flexible, and contract terms will reflect negotiated choices. You need to know your costs and the cost drivers. And I'd really encourage you to experiment with different choices. If there is a gap between your expected effort and cost and the payment that's offered, and you really need to focus on, develop, and nurture your payer-provider relationships. Next slide, please. So as I mentioned, this webinar is really sort of an introduction to the in-person workshops that we're going to be holding next month. It'll be 3 hours long. We're holding the content and approach. It'll be a more in-depth exploration of issues presented in the webinar. There'll be some case studies from groups that have been providing palliative care, both to Medi-Cal and non-Medi-Cal populations, and there'll be some worksheets to help you in thinking about this issue of the variables that drive the cost of care delivery. The approach will be participatory with opportunities for you to share strategies with the folks who are in the room, and we're aiming for small groups, so no more than 20. And you can have some time to plan with your colleagues if more than one person is coming from a particular organization. In terms of who these workshops are intended for, we're really hoping to pull in individuals from provider organizations, so teams of 1 to 4 people with knowledge of administrative fiscal operations, the needs of the target population, and the current proposed care model, as well as individuals from payer organizations who have an interest in this topic. And we're offering 4 workshops, and the registration for that is open through noon tomorrow. So there's going to be 2 workshops in Southern California, one on the 4th and one on the 5th. Both of these run, I believe, from 11:30 in the morning until 3 in the afternoon. And then there'll be 2 in Northern California, one on the 25th and one on the 27th in the same time slot. So if you have not done so and you would like to register for a workshop, we had to go from 3 to 4, and so there are openings, and we've shuffled some folks, so there are some openings in each of the 4 workshops. Just need to contact Glenda Paha by noon tomorrow, and there's her email address there. Next slide, please. So I just want to do a quick acknowledgement of my colleagues who've shared their knowledge and wisdom and experiences that have contributed to my understanding of the variables that impact the cost of delivering palliative care, with special thanks to my partner in this effort, Ann Kinderman from Zuckerberg San Francisco General, Brian Castle, and the team that's working on the CAPC Accelerator Initiative, and then also the payers and providers and the project staff that participated in the Payer Provider Initiative that CHCF sponsored. If you have questions about the Technical Assistance Series, you can contact Glenda, and there's her email address there. There's also a dedicated web page on the CHCF website, and we've given you the URL. As I mentioned, the webinar recording and slides will be distributed early next week. And I just want to thank you all for your time and your attention, and for hanging out for an hour today. And I think we can take time for one or two questions. So.
Great, Kathleen, thank you so much. This is Kate Myers from the California Healthcare Foundation. I just want to thank Kathleen for that amazing overview. You put a lot of information into 1 hour, so thank you for the information and overview. There was one question that came in that I want to read off, and then if anyone else wants to type in a question, we probably have time for maybe one more than this one. So the one that came in just a few minutes ago, Kathleen, is care coordination will be a large part of these programs and services. We have only found one code for care coordination, 99490. Is there another code which can be used with a higher reimbursement than, I guess this is $36.99, $36.99, I believe, for care coordination codes?
Yeah, so I do not believe so, but I will have a look. The other thing that I would say is that I think it's really important to familiarize yourself with the existing fee-for-service options that exist around delivering care coordination. But I'd also encourage you, as you speak to payer partners, about getting away from the idea potentially of having a fee-for-service based revenue model, and to think instead about something that's more along the lines of, say, a per enrolled member per month payment that would be better suited to, as you say, providing the very intensive care coordination work that these patients need, but which isn't really adequately compensated through the existing codes and fee models. They also don't do a very good job of, say, providing for payment for nurses and social workers and chaplains who would be very involved in delivering this care, but where there's no code for compensating for their services. So great question. Yes, the code compensation is really low, but I'd really encourage you to think beyond the concept of encounter-based fee-for-service payment when you're thinking of delivering the SB 1004 palliative care.
Okay, I think we have time for one more quick question that came in, and then we'll close. It is Chaplain Services, required or recommended? Please clarify. Thank you.
The Chaplain Services language, let me pull that. go right to the APL, make sure I got it right. Chaplain Services, DHCS recommends that NCPs provide access to chaplain services as part of the palliative care team. So you're right, it's a recommendation. It is not a requirement. And they do provide the caveat that chaplain services provided as palliative care are not reimbursable. So you can't, there's no code for delivering chaplaincy services. It is on the list. It does have that caveat that it's recommended. I apologize.
And one other last comment came in that I'll just mention because I don't think it's a question, I think it's more of a comment, is that health plans could actually collaborate with, say, both an established clinic-based palliative care program as well as a home-based palliative care program to care for this patient population. It doesn't have to be one or the other. They're not mutually exclusive. Would you agree with that, Kathleen? Yeah.
I would, and I think, you know, if you look at the populations, you know, you could really see something like that working, say, with the cancer population, where they may be going to clinic after they have qualified for SB 1004 palliative care to be getting their disease-directed care. It would be possible and perhaps more convenient for them to also be accessing clinic-based palliative care, and then maybe that patient would eventually transition into receiving home-based services as disease progresses. So absolutely, it doesn't have to be just one organization, and just one organization may not be optimal when you think of needs and efficiency and what the patient and family might prefer.
Okay, with that, we are now 2 minutes past the hour, so we're going to close. But if there are follow-up questions that didn't get answered, you can funnel those to Glenda Paja, and she'll get those to either me or Kathleen or Ann, and we'll make sure those get answered. But again, I want to thank Kathleen and Ann for the development of this content, and Kathleen for presenting it today. And thank all of you for participating. And please let us know if you have questions, and if you're interested in signing up for one of those workshops and haven't already, please contact Glenda Paja by noon tomorrow. Thanks so much, everyone. Bye-bye.